Can you hear me now? Do you care? Thank you all for coming. Before I turn this over to Henry Logan, who will introduce our wonderful guest, just want to make one announcement. We don't meet in June, July, and August, but I have hopefully ordered a bus June 28th, which is a Sunday. The League of Women Voters, the Gainesville League, will hold a forum before the primaries, and it'll be at the Graham Center. So if I get the bus, I will let you know. And I think we would leave at 1 in the afternoon and be done at 4:30. But this is for the primaries, which happen in August. And someone asked me, well, who will they have there? I don't think they know yet because it's June 12th when the registration to run ends. So I don't know how many candidates will be at the forum. But once I know, I'll let you know and hope some of you can come. Now I'll turn it over to Henry.
Well, it's a lot of fun for me to be able to introduce our speaker for tonight. This Brooklyn kid was the dean of the dental school at the University of Florida, and he was also president of the American Dental Education Association, and he also had the great wisdom to hire me in 1999 to come to the University of Florida from the University of Iowa. In about 2006, Frank's office was just around the corner from mine. This man was so excited because he was going to Alaska. The dental therapists had begun there because of the remoteness and the lack of dental care. And he was just plain interested. He went up there, he came back even more excited about the concept. This is 2006. Got more dentists to go with him. They'd go up there because there weren't a lot of outside dentists that wanted to go to Alaska and help with this program with dental therapists. Then lo and behold, this man got the hot idea, we've got a lot of health needs in the state of Florida. Maybe we could get dental therapists in Florida. The Dental Association said, what are you talking about? What are you talking about? I went with him a couple of times, and then he began to get the idea of getting some legislation going. And in 2011, I believe, that's when they began the process. This man is a Don Quixote, if there ever was one. And so I introduce to you Dr. Frank Calinato.
Thank you very much. Well, pleasure to be. The League of Women Voters across the state has been big supporters of our effort for the 10 years that we have been, now our 11th year, trying to get this legislation passed. So I want to make a comment about the title first. So when I accepted this invitation, we were so close to passing this legislation that I would have had the subtitle, Politics is the Art of the Possible. I phrase that as Politics is the Art of Compromise. And in the last 4 days of session, our bill fell apart. And I'll explain why. But that's why I then picked the other title. Politics is like making sausage. It's not a very pretty process to watch. And I'll tell you, as I get towards the end, I'm going to spend a fair amount of time trying to talk to you about the political process, because I think you will find that of interest. Now it's not working. Okay, so a lot of things I'm going to try to cover in this. Some of them are going to be like one slide when I talk about the national scene. But I want to help you understand what dental therapy is, why we need it in our state in particular, and then the political process of getting this done in Florida. As Henry said, we're actually entering our 11th year. and we're not the worst state. I mean, it took Washington 10 years. It took Michigan 10 years. I remember going to a Michigan meeting about dental therapy well over 10 years ago. Not working again. You can, if you, yeah, you can advance. Yeah. So I use this to start because I think it's a great quote about the issue of healthcare. Henry described me as a kid from Brooklyn. I'm a middle-class white kid from Brooklyn who never really understood poverty until I spent a couple of weeks in a border town in San Elizario, Texas. And in particular, when I spent several years in New Jersey and had a research project on HIV in children, and I got to go into homes in the Newark area of New Jersey, poor, poverty-stricken homes. And it was sort of like an enlightenment to me about there's something wrong in this country, particularly when it relates to healthcare. So we use the term inequity. Some of you may have heard the term disparities used before about unequal differences. We use the term inequity because what we've discovered by looking at the literature is that healthcare, for oral healthcare, access to oral healthcare is not randomly distributed in our society. It affects certain groups of people more than it affects others. Certainly the poor, cash-strapped families, members of communities of color, elderly patients who are homebound in particular, who can't get access to care, immigrant populations, and in particular those with developmental disabilities and other special health care needs. They just have a tough time getting access to health. Why do we have this problem? The biggest issue everywhere, all sources, it's cost. Dental care is just damn expensive. Okay? Number two, you've got this issue of what we call the social determinants of health. I mean, if you don't have a car and you have to rely on public transportation because you're poor to get to your dental office, that's a problem. If you don't have enough of the right education to understand the importance of oral health, that is a problem. And then we have this issue, particularly in our state, of a shortage and a maldistribution of dentists, and I'll describe that in a little bit more detail. And then the last issue in our state in particular is very few Florida dentists take Medicaid patients. The stated public number is about 18%, but the reality is we only look at those who see at least 100 patients a year, and that's just a little more than 10% of Florida dentists. And we rank near the bottom of the country in terms of Medicaid utilization, and I'll explain what that means in a minute. It's not going again. So Florida ranks, this is now all children, not just those on Medicaid. We rank last in the percentage of children with or without insurance who've had a dental visit in the previous year. This was about 2024 data. And out of the 50 states, we rank near the bottom. We rank 42nd for adults getting dental care. So this is a problem not just for children, this is a problem for adults also. So here's the first indicator of what I mean by this shortage of dentists and this maldistribution. The federal government declares areas of the country as dental health professional shortage areas. They don't have enough dentists to meet the needs of the population in that area. Nearly 66 of 67 counties in Florida have some designation of the dental health professional shortage areas. I actually just found out, we haven't had time to add it to the slides yet, that there are 2 counties that actually don't have any dentists in them. To fix that need would take about 1,300 dentists. It's not going to happen. We only graduate about 350 dentists a year between the 3 dental schools. And none of these numbers about this shortage account for the fact that our population is growing rapidly in our state. And then the last figure I would point to you is that the dentist population ratio across the country is 59 dentists per 100,000. In Florida, it's only 51. So when the opposition to dental therapy says there's no shortage of dentists in our state, they just don't look at their own data, their own published national data about this. I should also add that 6 million people, the next two states combined don't equal 6 million people. We are the worst in the country. Not clicking again. I mentioned that this is a racial equity issue, and this is just an indicator of that. If you look at tooth loss in Black adults, much higher percentage have more tooth loss than the white population, the Hispanic population. And in particular, if you look at the economic impact of that, think about it. If you're going for a job and you have badly broken down teeth, missing teeth, are you going to get the better job maybe in the front of the office, or are you going to get the job back in the warehouse? You're going to get the lower paying job. Next slide. Medicaid utilization. The percentage of patients on Medicaid who got a dental service in the previous year. So for adults in Florida, tough luck. We have very, very poor benefits for adults, basically extractions and one denture in your lifetime. Federal law requires that Medicaid provide benefits to children. Nationally, the country doesn't do too well. The national Medicaid utilization rate is 49%. In Florida, it was only 39%, ranking us usually in any one year somewhere between the 5th worst and the worst state in the country in terms of Medicaid. What that number really means, though, because we have so many kids on Medicaid in our state, is that 1,200 kids that year did not get any kind of dental care that were on Medicaid. And we'll talk in a few minutes about why that's important. Next slide. This is the one that I hope that shocks you the most and gets you the most attention, because this is all a waste of money. So when you get a bad toothache and an infection and swelling, and you call a dentist office in town, and they say, well, no, we don't take Medicaid, but if you come in and bring in $250, we'll get you some dental care, we'll take care of your problem. They can't afford that. So what do? They go to the hospital emergency department, which is required by law to see you. Okay? We are the worst state in the country. 146,000 visits in 2024 for these preventable dental conditions. 4,000 people admitted to the hospital because the infection was life-threatening. And that middle line, close to $1 billion the hospital billed out for this. Now, this is all wasted money, because the only thing that happens in the hospital emergency room is antibiotics and pain medication, and you're told to go see a dentist tomorrow. Well, if you couldn't afford a dentist today, you're not going to be able to see one tomorrow. And Medicaid is the primary payer in Florida for these problems. Next slide. We're also the state with the highest number of what we call superutilizers. People who go to the hospital emergency room for the same problem at least 4 times in 1 year. And we rank #1 in superutilizers of the emergency room. Again, all wasted money. Because what happens? They get better when they get the antibiotics and the pain medication. Their infection goes away, comes back a couple of weeks to a couple of months later. They go back to the emergency room for the same problem. So do we have a problem in Florida? No doubt about it. And I'm not the only one who says this. So here, this is an article written by the chief of the Health Policy Institute at the American Dental Association. Just a great piece. I'm amazed that they let him publish this in their journal, that Our dental care system is stuck. Basically, it was broken. This is across the country. But Florida happens to be one of the worst states in terms of this problem. Next slide. Okay, so a little bit about why oral health is important. And this is something, maybe a takeaway for some of you in terms of thinking about this. So there are obvious things. It affects the ability to eat and drink, your diet and nutrition. If you can't chew food properly, this issue of self-confidence and mental health, if you don't look good, the ability to concentrate and work in school, and I'll talk about that in a minute, and the likelihood of getting and holding work. And there's clear literature about this. People with poor oral health, bad-looking teeth, have a difficult time getting jobs. Next slide. But here's where the real rub is. The science is now very clear. Poor oral health in adults, in particular gum disease, periodontal disease, is linked to the management of diabetes. It's been linked to cardiovascular disease, arthritis, and in particular pregnancy outcomes. Okay? All these things have long-term impact on people's health. Next slide. And in children, what is the way out of poverty for poor children? The way out of poverty is learning, being educated, being able to get a good job. The science is absolutely clear. Children with poor oral health, in this case cavities and dental pain, just do not do as well in school. Their academic performance is limited, is not as normal as other children in school. It also affects self-confidence and emotional development. Next slide. Work hours. When mom or dad has to take off several hours of work, take Johnny to the dentist, he or she is usually on an hourly job. They miss work, they miss pay. Dentist offices are not opened at convenient times for working parents, like Saturdays and Sundays and evenings. And again, all of this is backed up by published peer-reviewed papers documenting these changes. Next slide. Here's one estimate from one group. Diabetes alone, if you could fix periodontal disease in diabetics, you'd save over $7 billion in healthcare costs. And I could go on, but you get the point of what I'm trying to say. The link is clear, and there's now data to show that poor oral health impacts overall health, and that ends up costing money, costing you in healthcare costs, whether it be hospitalization. Next slide. So, how do we deal with these problems? We have chosen to focus on one area, and that's workforce and dental therapists. And I'll get into the reasons why we do. But there's lots of other ways to approach this. And other organizations push different aspects of this. So there's another organization in Florida called Florida Voices for Health. And they are working on issues related to kids with disabilities. They're working on getting adult Medicaid benefits. We made the decision to stay laser focused on workforce and dental therapists. And I'll explain why in a minute. Next slide. So what are dental therapists? Okay, no, the couch is not relevant. It's there meant as a joke. Dental therapists are not people who help you get through dental care. Next slide. This is about a 100-year-old profession. It started in New Zealand. It's now in about 50 countries around the world for at least 100 years. It's been, I got to update that, it's now 22 years in the United States, started in Alaska when the tribal organizations up there were just tired of the lack of good quality dental care that they were getting through the Indian Health Service and volunteer dentists who would go up there, provide some care for a day or two or three, and then go hunting and fishing. All right, that's not a system that works. It's now authorized in 14 states. Next slide. We have sort of a standard definition that we use. They're oral health professionals. They work on teams with dentists and dental hygienists. They must be hired by a dentist. The legislation says that. And they are educated to a very high level, but for a small, limited number of procedures. They can't do all the procedures your dentist would do to you. Next slide. So what are the kinds of things they can do? They can take x-rays, they can do examinations, they can do something we call treatment planning, which is figure out what you need. Is that within their scope of practice? Or does that have to be referred to their supervising dentist? And they might, if not, they might make referrals. For prevention kinds of things, they can teach you how to take care of your teeth. They do cleanings, they do sealants, they do fluoride varnish. These are products and procedures that your dental hygienist can do. But the big difference is they can place fillings in teeth. They can drill a cavity in a tooth, take out the decay, the bad part. They can put on what we call stainless steel crowns, usually used for baby teeth. They can extract permanent teeth. They can extract primary teeth, baby teeth. They can also extract permanent teeth that are so mobile, you can wiggle them with your fingers. That's called a class 3 mobility technical term that we use. And they can dispense and administer medications. They can provide local anesthesia. They don't do dentures. They don't do implants. They don't do root canal therapy. They don't do periodontal surgery. They don't do complex extractions. That's why they can be educated in a shorter period of time. Their education period is two full-time years or 3 academic years, compared to a dentist who goes to college for 4 years and then goes to dental school for 4 years. Next slide. And where are they working? They work in private practices. They very frequently work in safety net organizations, particularly in Minnesota, which was the second state to get them started. One of the powers of how they can do what they do so well is they can work under the concept of what we call general supervision. So that means that the dentist does not have to be there in the office. That means they can go out to a school, they can go out to a nursing home. In Alaska, they literally, God's honest truth, because I've seen this in action, they fly out on Monday mornings in a prop plane with a pilot with their portable equipment. They set up in a medical hut in a small community of 400 people where there are no roads to get there, and they take care of teeth until they're done. And on Friday or Thursday afternoon, they fly back to Bethel, which is the home base for a lot of them or they live in these small communities because that's where they're from, and they don't want to move. They want to stay in those rural, underserved communities. Next slide. So the tipping point about the progress of dental therapy. So I should go back up and say for a minute, and I'll explain more about this in a minute. There's only one opponent to the dental therapist, and that's organized dentistry, the American Dental Association, the Florida Dental Association in our case. But the tipping point came when the Commission on Dental Accreditation, which by the way is housed in the American Dental Association building in Chicago, any of that, passed accreditation standards. So they are accredited just like my dental school was accredited, University of Florida College of Dentistry is accredited. That means they have to meet certain requirements in terms of quality, safety, the importance of the education, what happens during the educational process. Next slide. The other thing that assures quality is they actually take the exact same clinical licensure exam that dentists take, except that it's limited to their scope of practice. The exact same exam. The irony of the 2024 exam is on the right side of that, where they had a higher pass rate than the dentist did. Now, we'll laugh at that, but there's a reason why. When my dental students graduate from the University of Florida College of Dentistry, they might do one procedure that we call a pulpotomy on a baby tooth. It's taking out the pulp chamber and putting on a stainless steel crown. Dental therapy students do 5 to 10 in their educational period. They don't have a lot of other stuff to learn. They don't have to learn how to make dentures. They focus on these limited number of procedures. So, what what happened in, I haven't actually looked at what happened in the 25 exam or the 26 exam, but I want to point this out. These are safe, high-quality practitioners. Next slide. So, again, I make this point as much as I can. We have standards in place to make sure that there's high-quality care, the Commission on Dental Accreditation, the clinical licensure exam, and they must be supervised by a dentist. Next slide. Why is this important? Okay, it's important for local communities because what we're looking for, particularly in Florida, is we're not going to place these dental therapy educational programs in state colleges or dental schools. We're going to place them in local community state colleges, in rural communities where we can. Because we're going to try to attract students from those communities and hope that they end up staying in those communities. They create good paying jobs. I can tell you that in Alaska, a dental therapist is one of the most well-off people in town, and they don't have really high salaries. But that the nature of the economy up there, they become well-paid citizens. Next slide. This is good for dentists, okay? Dental therapists help reduce the cost of delivering care. So a federally qualified community health center, a safety net organization, can now afford the miserable Medicaid reimbursement rates because the dental therapist makes a lower salary than they would for a dentist. Same thing with the dentist. What we're seeing in Minnesota is dentists in private practice are now, after 12 years, are now hiring dental therapists. Why? They have to see Medicaid patients, so they're doing a social good, but they're actually making more money because the dental therapist is seeing the easy work, leaving the dentist more time to do the complex work that generates higher fees. Next slide. And it's good for patients. Okay. Again, literature, mostly from Minnesota, where we have our best experiences and the most number of dental therapists. Decreased wait times for appointments, usually care where they live and work. And there's clear evidence of actual improved oral health in patients who've been treated by them. So again, the bottom line, there's no question about the quality, the safety, and the cost effectiveness. And again, we'll address that. 22 years of experience now in the United States, in addition to the 100 years of experience worldwide, and about 150 peer-reviewed published papers attesting to the quality and safety. Next slide. So, first a comment about the slide in Pinocchio, and the first slide that you saw with that sign about, Florida welcomes you to the toothache state. 3 or 4 years ago, my organization, Floridians for Dental Access, joined another organization called American Children's Campaign. This is a long-term state advocacy organization that has passed lots of legislation for children. They joined our efforts. They have a strong communications team, and they have redesigned all of our communication products. They're the ones who came up with the Pinocchio look to talk about the Dental Association. There's only one opponent to dental therapy, as I said before, it's the Florida Dental Association. And we use Pinocchio because they just tell lies. They tell myths. They tell misrepresentations of the data about dental therapy. Next slide. They actually have a toolkit that they use to help dentists deal with legislators who might want to pass dental therapy legislation. In the next slide. And this is embarrassing for me as a dentist to share this with you because they actually basically tell the dentists that when you talk with legislators, don't talk about quality because the quality studies are all out there showing that dental therapists provide safe, high-quality, cost-effective care. What they tell them is when you get them in the office, tell them scary stories about dentistry and what could happen with a person with a needle who doesn't have enough experience or uses that high-speed drill. They just lie. Next slide. They use their favorite term, irreversible surgical procedure. That means cutting a cavity in a tooth. That's all that it means. Next slide. Local anesthesia. Dental therapists are trained just as well as I was trained to provide local anesthesia with a needle and a local anesthetic. Next slide. Dental therapists will create a two-tiered system of care. You know, the care for the rich people who can afford to go to the dentist, and then care for the poor people. Well, my response to that is we already have a two-tiered system of care in this country, those who can get care and those who can't. If you believe the literature that they are safe, high quality, and cost effective, and they improve oral health outcomes, this is just simply not true. Next slide. We already have solutions in place. We don't need those dental therapists in our state. Next slide. So you may have heard of Missions of Mercy. There's actually going to be one in Gainesville in the next month or two. It's being run by an organization called RAM, Remote Area Medical. But the Florida Dental Association is going to adopt it as one of their missions of mercy. They literally fly in a big tent, 30 or 40 dental chairs. They look for local dentists to volunteer, and I applaud those who do that work and volunteer to do that. But that's charity care. They don't tell you that some patients wait online, I am not kidding you, 24 hours. They are lined up the night before to get one tooth taken care of when they go to these missions of mercy. Philanthropic care is wonderful. I wish more dentists did it, but it is not a system of care. It is not a way to let people walk away with dignity after they've had their dental filling or their tooth taken out. Next slide. Even the American Dental Association said in 2012, charity care is not the way we want to solve the access problem. Next slide. And this is just an example. So we've been doing Missions of Mercy in Florida for about 10 years. We looked at the reports coming out from this. 13,000 people got dental care over the last 10 years at a Mission of Mercy. Think about 6 million people living in dental health professional shortage areas. Think about 1.2 million children that on Medicaid who didn't get dental care. 13,000, 14,000 patients is a drop in the bucket. This is not the way to solve this problem. You need to get regular access to locally based community providers. Next slide. Loan forgiveness. Loan forgiveness is a process by which the state or the federal government will give a loan to a dentist to pay off their educational debt if they work in an underserved area for a couple of years. It works in the short term. However, it does not work in the long term. Having said that, I still support loans because it at least gets some temporary support. And we have a growing loan forgiveness program in the state of Florida. It funds about 10 dentists a year to go into rural and remote areas. Again, think about that with the fact that we have 6 million people living in dental health professional shortage areas, 1.2 million kids on Medicaid not getting services. It doesn't touch the problem at all. Next slide. We need more dentists. Let's create more dental schools. This is not the answer, okay? We need, just on that 6 million figure, we need about 1,200, 1,300 dentists in the state of Florida. This number grows every day, every year that more people move into Florida. We only graduate 330 dentists a year. But the other problem is dental schools are just damn expensive. We're doing a renovation to our dental school here at the University of Florida. We're looking at $100 million just for a renovation and a new building. Okay. Other dental schools, we've had one other new and open in the last couple of years. We're talking 50, 60, $100 million, depending on how you finance it. Okay? Then those dental students have to go to college for 4 years and accumulate debt. They have to go to dental school for 4 more years and accumulate more debt. Our students are graduating with over $250,000 in debt. Do you think they want to go work in a rural community, an underserved community, and serve Medicaid patients? No, they don't. So more dentists is not the answer to this problem. Next slide. So for all the criticism we get of dental therapists by dentists, I always point out this paper in the Journal of the American Dental Association. Tim Wright is a dental faculty member at the University of North Carolina. He was chair of the Scientific Affairs Committee of the American Dental Association. And look at his quote. The results of a variety of studies indicate that appropriately trained mid-level providers, dental therapists, are capable of providing high-quality services, including irreversible procedures such as restorative care and extractions. So even the American Dental Association says that dental therapy works. But that doesn't matter to the mainstream dentist, and in particular, in our case, the Florida Dental Association. Next slide. There are about 1,500 international papers on dental therapy. And as I said earlier, about 150 papers since we've had them in the United States since 22 years now, starting in Alaska, then Minnesota, and now in several other states. Okay? The data is very, very clear. My favorite question to ask an opponent of dental therapy when they say they're not safe: do you have any data to support your opinion that they're not safe? And then it's either stone silence or they, well, in my opinion, in my experience, I went to school for 8 years, they can't be as good as I am. It's just simply not true. There's just no data to support the opposite. Next slide. All right, so as Henrietta said, 2006, I heard about the program in Alaska. I called them up, said, could I come up and visit? I was very interested in access issues for reasons I mentioned earlier. I went up and I spent a week up there, and I went up at just the right time. I didn't realize it was the right time. It was December, the end of their first year in Anchorage, Alaska. Anyone been to Alaska in December? Not a great spot to be. I didn't see the sun for a week. I was there for an entire week. I did have one sort of sunny, semi-sunny day. The first day I was there, I went to see a museum of Alaskan Native American history. The rest of the time it was rainy, freezing, sleeting, and I mean, I used to drive in that kind of weather in New York and New Jersey, but I sort of forgot how to drive in that weather, and it was fun for the week. But I went there when they were having their end of the year exam, and they had another person come in who was on the State Board of Dentistry, and we examined all the work they did that week. Some of the work was done on models, some of the work was done on patients, and I was just amazed. They were as good as the dental students were at this stage in their career. Right? And they had only been educated 1 year. Our dental students don't start to see patients until about the end of their second year, the beginning of their third year. I became convinced that this was a viable solution to part of the access problem. With the slide I showed earlier, lots of ways to approach that. Dental therapy is just one. So I read everything I could about it. And I knew about the Florida Dental Association, so I didn't try to get any effort started. But I went around to almost every one of those states. I made multiple visits to Alaska and Minnesota, which had an active program. And I provided testimony in Wisconsin, Washington, New Mexico, a bunch of other states. I met with legislators on behalf of local coalitions and provided testimony. And we're now at the point where we have 14 states that have passed dental therapy in some way or another. We're now part of the mix of other states that are thinking about this. New York, another really big state, is actually very close to passing legislation very early in their process. We'll see what happens in the next couple of months. California is just gearing up an effort. So the national sort of consensus is if those three states go in support of dental therapy, this will be the tipping point for the rest of the country to make this happen. Next slide. So about 11 years ago, one of my friends said to me, well, if this is so good, why not in Florida? And I said, you're right. Maybe it's time to do this. So at that time, the Pew Trust in Washington was funding efforts for dental therapy. And I called the people up at the Pew Trust. I knew them already because I had been doing advocacy work for them in other states. And they said, yeah, might be fun to try Florida. We know it's going to be a difficult state because of the dental situation. We'll give you 6 months. See if you can find a couple of other organizations that would be willing to support you in this effort. And they actually even gave me a person to work with. Well, a month later, I had 35 organizations across the state that said they would be willing to support this effort. So we started our legislative efforts at that point in time. We got close several times in the early years, and then we just sort of waded through opposition, but didn't make a lot of real progress until 3 or 4 years ago, when a new funder came on the scene. Pew Trust dropped out of this activity. And an organization called CareQuest, Institute for Oral Health, they were one of these spinoffs, you know, when you've heard of the story where hospitals get sold and the profit goes to a not-for-profit. Well, a Medicaid supplier in Florida, DentaQuest, got sold to a Canadian insurance company. The profit was well over $1 billion. I actually don't know the real dollar amount, but well over $1 billion. And with that, they formed the CareQuest Institute for Oral Health. And they started funding a variety of oral health initiatives across the country. One of them was on dental therapy. And I applied for some money for them, and they gave us a start. This was about 4 years ago. 3 years ago, and we made a little bit of progress, but not a lot. 3 years ago, I had been writing to an organization called American Children's Campaign for a year, and they ignored my emails. And I finally just called up the executive director, Roy Miller. Roy is a long-term children's advocate in Florida. He used to actually run political campaigns, so he's got a lot of political smarts. And then he got asked by the governor, whoever that was about 25, 30 years ago, to help pass some legislation for children. And he formed a not-for-profit American Children's Campaign, and they have been passing children's legislation all this time. He took my phone call, I explained the problem, they joined our efforts. They brought along a lot more political savvy than I had. They brought along a communications team that just has revamped all of our communication products. And I'm going to go slow during this next period because I want to give you a flavor of the political process, not just our progress in dental. So when we got our original bill, our sponsor was a freshman legislator named Danny Perez from Miami. So if you know anything about politics, Danny Perez is now the Speaker of the House. unfortunately only for 3 or 4 months before 6 months. He helped us move this along really well. He still wanted to support this. He picked out the person who would be the House sponsor for this, for the bill. We didn't have good connections in the Senate. So in 24, we passed 2 House committees, but never got to the full House. That's progress compared to what we did before. In 25, we passed the committees again, and we passed the full House. And we were hoping to link to the Senate president at that time, now still the Senate president, Ben Albritton, a farmer from a rural county, who was putting forth what he called his Rural Renaissance Bill, economic development for rural counties, including better access to health care. Problem is, we just could not get his attention. Why? There were 2 key committees in the Senate that any health care bill had to pass through. Both chairs, I like to say, were in the pocket of the Florida Dental Association. They did whatever the Florida Dental Association, and they wouldn't even give us a hearing on this legislation. So at this point, other thing I should mention is, I mean, passing legislation is hard work. It's really difficult. You need to have a lobbyist. A lobbyist is absolutely critical from my perspective. We have a wonderful lobbyist. She's been our lobbyist for 10 years, 11 years that we've been doing this. So we get to 2026. We pass in the House. We're still having problems going to the Senate. And my funder did something which I had not seen them do before in any other state. They called us up and said, we want to hire a lobbyist for you in addition to your lobbyist. Who should we hire? And our team met with our lobbyist, and we said, last names are not important, Andrew and Eileen. He used to be the chief of staff for the Senate president. She had a really important job in the legislature also. They will get us through this. So we recommended to CareQuest that they hire them. They did. It took 1 week. We signed a contract with them. They were on the job 6 days. And they said, we have a meeting with the Senate president. Key step. We get into the Senate president, explain the legislation to him, explain how it's going to help rural counties, and he becomes an avid supporter. So here's where the sausage comes in on this process. You all know the obvious disarray going on in the country in terms of politics. Okay? The reason for that is very different than what's happening in Florida. The reason for that is we have Republicans and Democrats who will not work together, and they will not compromise. It's as simple as that. Look, there's good people and bad people in both parties in terms of legislators. But Tip O'Neill, for those of you who are old enough to remember him, he was a representative from Massachusetts, used that common phrase that I mentioned in the beginning, politics is the art of compromise. You've got to have compromise. Bill Clinton, a lot of the stuff that he passed was based on compromise between warring Republicans and Democrats. They came together on certain issues. They walked away, I like to say, so that neither one was really happy, but they got a little bit of what they wanted. Okay? The problem in Florida is different. The Republicans have a supermajority. They should be able to do anything they want to do. But they are the cause of the problem in our state and what happened to our legislation and other legislation. This was a battle between, I hate to say it, Danny Perez, my original bill sponsor, and the president of the Senate, both Republicans. Danny Perez wanted a certain number of things done. the president of the Senate wanted a certain number of things done, including his World Renaissance bill. And the governor sitting out there, wherever he was sitting, wanted his things done. A whole bunch of bills fell apart, not just our bill, in the last couple of days of session, because the Republicans agreed. They left Tallahassee at the end of session without doing the one thing they are legally required to do. That is to pass a budget. They went back in session today, special session, and they're hopeful. I actually had a team meeting yesterday, and I'm speaking with our lobbyists. They're hopeful that they'll actually pass a budget resolution by the end of 2 weeks. But she said, Frank, you can't be sure. Okay, so it's totally different than what's going on nationally. This is internal fighting. You know, each of the three leaders wanted their own thing, and if they couldn't get it, they blocked the thing the other house wanted, or the governor wanted. So we got so close, as I said. I mean, literally, we had a team phone call on the Sunday before session ended, and a lobbyist said the Senate president is actually working the bill over the weekend, calling up senators to support it. She later explained to us is that he was not the strongest Senate president. When Speaker Perez said to a legislator, jump, the legislator said, how high should I jump? In the Senate, Ben Alberton, he's a farmer. He's actually a nice man. He let too much power drift from his office. And those two committees that I mentioned earlier still had their chairs and bucked him all the way till the end. So on Monday morning, telling you the day by day how this went. On Monday morning, our lobbyist said, well, there's two committees that it could go to. So actually, the part of the story I didn't tell you. So we actually did not have a bill in the Senate. The plan was to tack the House bill onto part of the Rural Renaissance bill, not being a freestanding bill. On Friday, the lobbyist said, no, we're changing the strategy. We're going to get a bill. We're going to have them hear the House bill in the Senate. On Monday, I told you there were two committees that could have gone to the Rules Committee or the Health Policy Committee. We needed to go to Health Policy. And on Tuesday morning, it was announced it was going to Rules, which meant somebody was killing it from behind the scenes. So obviously, we were grossly disappointed in this. We just got so close. So I had conversations with my funder, and they said, Frank, we want you to try again. So they gave me a new grant starting April 1st. And at this point, it looks like they're going to rehire the lobbyists because we really need that help. This is such a hard wheelbarrow to carry to Tallahassee. The organization has grown to over 600 either organizations or individuals. And we are going 100% full speed ahead trying to get this done. We're going to try and visit almost every legislator that we can between now and the start of session next year. So this is an election year, so session doesn't start until after January. I think it's actually March. So we have lots of months to meet with people and get this done. And there's a lot of national interest, as I said, in Florida, because Florida is one of those sort of big three states like New York and California. If we go, that's the tipping point. Next slide. So I want to talk a little more about political campaigning. So this Roy Miller fellow that I mentioned, he looks at dental therapy like getting a person elected to office. Okay. I'm the representation of that. I'm the spokesperson for our organization. So one of the first things we did was we did a scientific poll. You may have heard of the polling company, Mason-Dixon. They do polling. We polled, I think it was roughly about 1,000 people across the state of Florida, people who were already considered likely voters. And we found some interesting messages. Key message in Florida: Republicans would be willing to support improved access to health care. We thought this was more of a Democratic, progressive, liberal issue. There was almost equally as good support among Republicans. The money argument, the money that could be saved, was not an important issue to a lot of people. The fairness issue was fair access to health care. That poll and those results, which we share with nobody, except internally with our group, shapes all of our messages. Karen, our communications person, always goes back to that poll results when she designs our communication pieces. We have a social media presence. We are on Facebook, we're on X, we're on everything that you can think of, TikTok, sending out messages a couple of times a week about oral health issues, trying to reach as much people, as many people as we can. Our funder, CareQuest, has a very interesting mission. They want to see community-driven organizations. So we get a lot of patient stories. We collect patient stories about hardships in accessing dental care. Good thing is that I fully support Medicaid expansion. It ain't going to happen in a red state like Florida. It's happened in other red states, but not Florida, where I doubt we're going to see any kind of Medicaid expansion. But dental therapy is not part of that, what I call the culture wars. It's like community water fluoridation. I'm sure you've heard that our state has now banned community water fluoridation. The stupidest thing I've ever heard in my life, because the science is so clear on that. That's part of a culture war. That's not science. It's based on a cultural issue, a political issue. What we're trying to do is really make systems change in Florida in terms of the workforce. I've got 5 colleges that are already ready and willing to go and starting a dental therapy educational program if we pass the legislation. I think there's more, but those are the only 5 that have committed publicly. Next slide. This is our leadership board. We try to reflect the community that we're in, the state of Florida. We have someone who heads up an FQHC in Tallahassee. We have a dental hygienist who's just a passionate supporter about access to care, and in particular, I was talking with someone earlier, care for those with developmental disabilities. Miami-Dade College, a department chair. Actually, he's an acting dean right now. The head of the Florida Dental Hygienists Association, one of our biggest supporters. We've had great support, financial support from CareQuest. And again, we try and do storytelling as much as we can, getting patients through it. Next slide. To give you a representation, again, we have over 600 either organizations or individuals. We actually have about 50 dentists that have signed up to the Florida organization. Our support is bipartisan. This is a bipartisan issue in most states. The far right and the far left join together on dental. James Madison Institute, I don't know whether you've ever heard of that, a very conservative think tank in Tallahassee, and the Florida Policy Institute, a very progressive organization in Orlando. Both support dental therapy. Have done a joint editorial, op-ed, in support of it. Next slide. So, that's my story. How can you help? If you've got a story about dental access or know someone who's having problems, get the QR code and let us know. Join our coalition. We don't have any dues. All we're going to ask you to do is send an email to your legislator or make a phone call to your legislator's office at the right time this year. Or you can not join an organization and just get our newsletters and hear about what we're doing. And we try to send out something about once a month. During legislative time, we may go a little bit more frequently. And I should add that I may have said this in the beginning. The League has been one of our supporters from the early beginning, the statewide League. They email me every couple of months, what can we do? Is it time yet to start making phone calls, to talk to legislators? They are just wonderful. So I'm happy to answer any questions you may have. Thank you very much for your time. So let me make a comment. He was another early supporter. Why did he do this? I mean, why would a dentist do this? Well, in addition to serving you at Hammock, Carlos actually goes to patients' homes and delivers care in patients' homes because they're either bedridden, they can't get out of the home. That's expensive. You know, it costs him travel time where he's not reimbursed for that. But he sees the value of dental therapy. Dental therapists are providing dental care to patients in their homes, in senior living facilities, and I'm talking about frail, fragile elderly patients, and also patients with developmental disabilities. They can take care of the ones that are easier to manage, which leaves more time for the dentist to take care of the more complex patients. So that's Carlos and I go back quite a while. He's terrific.
Thank you. You've raised an incredible many thoughts in my head. As a kid who was poor when I was young and before fluoride, and I had very poor dental care. I've spent thousands since then. But I have a couple of, I'll just ask two questions to give time for other people. I thought fluoride solved all these problems for kids. That's first question. Second question is the Acorn Clinic still providing charity health dental care?
Yeah, let's go to fluoride first. So we've known that community water fluoridation at the right dosage level has been effective since about the 50s, right? All the studies show that it helps prevent, it doesn't stop. If a patient or a person does not brush their teeth properly, if parents put the child to bed at night with a bottle with milk, if they don't brush their teeth every day, my 14-month-old new granddaughter, I mean, her parents are brushing her teeth. You know, she doesn't like it, but they're brushing her teeth, all right? If you don't do those things, you're going to get cavities, okay? So fluoride is very effective. It works. We also now have it in toothpaste and other products that a dentist would use, but it's not the be-all and the end-all. So that's your second question. Okay, so Acorn. I feel very fortunate. My older daughter was the past president of the Acorn board. My younger daughter was a long-term member of the Acorn board, and I've been a past president of the Acorn board. So it's a family thing for us. Acorn went through some rough times. The medical group had to bow out a number of years ago for a variety of reasons. The dental group has been moseying along. We made a bad decision a couple of years ago and hired an executive director that did not do a very good job. And things almost got seriously bad. We have a brand new executive director. She is a local dentist from town who used to teach at Acorn years ago. She just literally started work about 3 months ago. We had a board meeting last night. I left the meeting breathless. She wore us out with the reports of what was happening. They have broken even every month that she's been there now for the last 3 months. She is going out meeting community organizations. We've hired a grant writing team, so she doesn't have to be writing grants. So Acorn, I am very optimistic, is back on the road to recovery. The need is terrific where it's located, and we're all pulling for her. We got a great board of volunteers, but basically we made the decision to not have her just be the chief dentist, but be the executive director. So she treats it like a private practice, except that the mission is care for the underserved. The mission is not making money. It is care. Payel, it's in Indian or Pakistan, but it starts with a B, Materia, something like that. I can get it to you. But first name is Payel. She used to work in Toga.
Another question?
Yeah, you provided so many good arguments why this is a no-brainer or something that we should be adopting in Florida. Yet why is the opposition so strong? I mean, is it just to maintain a monopoly and high fees, high returns?
So fear is one factor, okay? What will happen to me and my job if a lot of dentists are now employed, they're not in private practice anymore. I think we're well over the 50% mark. Greed, okay? They don't want to give up their monopoly. And the other thing is a thing I'll call just entrenched opposition to change. So when dental hygienists came about 100 years ago, guess who fought dental hygienists? The American Dental Association. What dental office would be without a dental hygienist today? I mean, every dentist has a dental hygienist. Okay? Expanded function dental assistants. It's a fancy term for dental assistants who can do a few more procedures than the regular dental assistant. Who fought EFTAs in Florida? The Florida Dental Association. We're one of the last states that allows dental hygienists to give local anesthesia. Who fought it? The Florida Dental Association. So it's this fear of change and flexing their muscle. You know, I said to you in the beginning, I hope my title would be Florida is, politics is the art of the possible. We were ready to negotiate. We spent hours developing a list of items that we would be willing to give up in our legislation if they would only come to the table and have a discussion, a sincere discussion about what their real objections were and what could we do with the legislation. We never got a chance to use it. It's sitting there waiting, and hopefully we'll use it next year. Okay. Now I will tell you that in other states, most of them have had similar opposition, but other states like Wisconsin and ultimately Michigan, they fought it for a long time, but they basically came to a compromise. All right. Now I don't like all the things that that's in their legislation, but they passed the legislation. And that's what, to me, is what's important.
Okay, I think we'll take two more questions. So,
Thank you for this good work. Yes, the countries that have universal health care, does that generally include dentistry? And how do these countries handle the underserved and the rural communities?
So let me answer the second question first. So yes, these countries that have universal access, it covers everybody, whether they're in rural or urban locations. Okay. I was surprised to find out that it's really funny that you asked that question. Literally only 2 or 3 weeks ago, I found out that many of these programs don't include dental. Okay. This was a big surprise to me. And I think it's going to change as they start to read this literature that's showing that if you can improve a patient's oral health, it actually saves money on the medical end. There's this wonderful study out of New York State. It's only about 4 years published now, where they went into the Medicaid system. They had data on both medical and dental. They had linked files. And they were able to show that those patients who got more preventive visits and fewer tooth fixing visits, restorations and extractions, had better health and spent less on Medicaid dollars. And so that's the kind of studies that we try to promote and show legislators that this will ultimately save money. But remember my poll that I did earlier, finances does not seem to be a big concern. The cost issues does not seem to be a big concern to either party.
Hi. My, my question is from the other side. If these dental therapists are so good and so capable of taking care of patients' general needs, dental needs, why do we have dentists go through 4 years of college and 4 years of dentistry? Because they cannot, after that, do root canal or implants. They have to do further training for that. So it seems to me they are doing the same thing as a general practitioner of dentistry.
So they actually don't have to go to specialty training. They can do, there are many dentists. My best friend is a dentist in Butler, Pennsylvania. He'd been doing root canals in his office, his entire practice until he retired a couple months ago, okay? They can do periodontal surgery. They can do difficult extractions if they're comfortable doing it. They can do limited orthodontics with just your dental degree. You do not have to go. Certainly dentures is a good example. Every dentist does dentures, all right? Dental therapists don't do dentures. It takes a lot of hours of curriculum time to learn how to make dentures, to do bridges, to do permanent crowns. Every dentist today, except children's dentists or other specialists, do implants and crowns on implants. So there's not a threat. There's so many underserved that, I mean, it would take decades of producing dental therapists, and I'd love to see at least 10 programs in the state of Florida with such a big state. Minnesota has 3 dental therapy educational programs now. So that's a misconception that they can't do those procedures. They do them.
Okay, well, let's give another hand to a very hardworking person here.
It might be easier. Hey, Bob.